Welcome everyone to this month's edition of Probing Literature. We're excited to have you all here. This month we're going over MSK soft tissue topics, and we're very fortunate to have two esteemed presenters today presenting their research. We have two awesome studies ready to go for y'all today. The first one is going to be presented by Dr. Jacob Schoeneck, entitled Abscess Pulsatility, a sonographic sign of osteomyelitis. Pretty cool indication for ultrasound that, to be honest with you, I wasn't super familiar with before getting into this. And the second one we'll have is Dr. Zachary Binder. He'll present his article entitled Ultrasound-Guided Nerve Block for Pediatric Femur Fractures in the Emergency Department, a prospective multi-center study. So really excited about these topics and excited to have our authors here to present. So we'll start off with Dr. Schoeneck. He is an assistant professor of emergency medicine and director of emergency ultrasound. He is the associate director of the fellowship at Wake Forest University School of Medicine in Winston-Salem. And Dr. Schoeneck lives there in Winston-Salem with his wife, Beth Ann, who is also an EM physician, which is pretty cool. They met during their residency at Yale, and they have three daughters, Zara, Amira, and Nora. Did I say that right?
Yep, that's correct.
Okay,
Yeah.
perfect. And it sounds like Nora is only 3.5 weeks old. Is that correct?
Yes, she is. We're almost out of that kind of magic 28-day window where we'd have to go visit my colleagues in the PMCID if she gets a fever.
Yeah, yeah. Wow. Well, hope everyone's doing well. Hope mom, baby are doing well.
can
Terrific.
everybody see the slides there? Excellent.
Yes, we
All
can
right. Well,
see it.
thank you so much for the opportunity to present this. This is actually a case report that we wrote up, but this is one of the more interesting ultrasound cases have ever had. Um, just a quick note on case reports here. They're kind of nice projects because they can be finished in a relatively or kind of short time frame. So they're really kind of ideal for involving your medical students who are interested in ultrasound, or some of your residents, because they all have to do a scholarly project during their residency, and so it's kind of nice for them to jump in and get involved on some of these. But for case reports, really, you're going to be looking for something that's rare, really rare pathology, a unique presentation of something that's a little more common, or kind of novel applications of ultrasound use. It can be helpful if you have multiple cases for that pathology. You're more likely to get something published as like a case series. And the most important part of this process, because we all kind of encounter these interesting cases in the ED, is getting patient consent. So the easiest time to do that is at the time that you're seeing the patient. But you can sometimes check in the EMR and look for other visits they have coming up, and contact them after the fact to try and touch base with them to get them to sign that consent form to use their images and the details of their case in a de-identified way for publication. When you're thinking about things that you want to put into a case report, they have this checklist from the care group, which is a kind of a nice summary of all of the main points that you want to include in the publication. And oftentimes, when you are looking at publication targets for their requirements, they will ask you to review this list and make sure that you have included everything that is listed here in the case report. And it can be helpful, with ultrasound images, we're kind of trying to show pictures and kind of as we move through the case. And so having some facility with video editing software and having that video prepared at the time you submit your case report can be helpful for getting them published. And some publication targets will ask for narration of that video. And so being able to, record your voice for that video presentation, kind of knowing how to have those skills can be helpful. So something to think about if you're considering doing a case report here. So this was a case of a patient with osteomyelitis, and I hadn't thought too much about POCUS for osteomyelitis before I had this case, but it actually can be a nice sort of adjunct to the rest of your initial evaluation if it's something you're considering in the differential. Oftentimes on a physical exam, it can be hard to differentiate osteo from other soft tissue infections. They present with swelling, erythema, pain, and as you'll see in this case, we had some kind of surprising findings that really kind of pointed us towards the diagnosis. And actually, the studies have shown that ultrasound detects some of the early changes of osteo sooner than X-ray does. And so while that's often the test that we're kind of getting from triage to assess for this, or thinking about to assess for osteo, POCUS can be really useful in the early evaluation. So this patient was a 68-year-old woman. She had a history of hypertension, hyperlipidemia, diabetes, rheumatoid arthritis, gout, and then had bilateral knee replacements. And she actually was on clindamycin prophylaxis from having previous knee joint replacements and infections in those joints that had to be operated on. She was coming in with 3 weeks of kind of upper left shin erythema, swelling, and pain, and she had been treated with ceftriaxone about 10 days before that without really any improvement in her symptoms. On exam, she had this area of erythema and swelling on the kind of anterior part of her shin that was tender to palpation. Her vitals were stable, and she didn't have a fever. As far as her lab workup, her white count was not elevated, and she did end up having elevated inflammatory markers that we did not have at the time that we did this ultrasound. But that we obtained those because we were worried about osteomyelitis. So. She'd gotten some plain films from triage that showed some, kind of swelling over the anterior tibia here without any, real cortical disruption or other kind of findings concerning for bony involvement. But when we went to do the ultrasound, we found this large kind of heterogeneous fluid collection that was right adjacent to the cortex of the tibia. And as we were scanning through, we found this area where there was a small defect in the cortex of the bone, and we could see what we thought was pulsatile flow, kind of communicating between the inner medulla of the bone and then this fluid collection. So we kind of zeroed in on that area, and on the left side you can see we have these this is a transverse view of the tibia, and you can see kind of right in the center there's this small defect with this pulsatile flow that you can even see on grayscale. And then we have an image on the right. This is a longitudinal image with a little bit more depth. And you can see that fluid collection goes well beneath the cortex of the bone and kind of down into the medullary cavity. So putting some Doppler over this, both color on the left and then just some power Doppler on the right, you can see that with the color Doppler, there is kind of alternating flow through this defect in the bone into the fluid collection, outside on in the soft tissues there. And assessing it, with spectral Doppler, you can see that there is, kind of low velocity flow of, 5 to 6 centimeters per second, kind of alternating back and forth through this defect. And so we ultimately, because of this pulsatile flow, we thought actually maybe that this was a hematoma, although she hadn't had any traumatic injuries. And we obtained a CTA to try to look for active extravasation or bleeding, from the medullary cavity into this area. And ultimately, it showed a large, looked like infectious fluid collection, as that was sort of our differential was, infection versus hematoma on the adjacent, anterior to the tibia here, and with communication into the medullary cortex. So, and ultimately, this led us to, consult orthopedics, from the ED for this infection that we otherwise might not have been concerned for osteo with. And we started her on broad spectrum antibiotics. She was ultimately admitted to medicine. And orthopedics had considered taking her to the operating room for like a washout and removal of all the hardware in that knee. But ultimately, they didn't think that this area was communicating with the knee joint or any of the adjacent hardware. And so they just did a bedside IND, which she did well with. And then she was discharged on 6 weeks of vancomycin through a PICC line. So So this is a case of pseudoflow, which is the registering of Doppler flow in any kind of fluid that is not in the vessels or related to bleeding. And we think in this case it was probably related to kind of the high pressure of that abscess invading into the medullary cavity and compressing some of those sinusoidal vessels in there. So we had what looked like bleeding or active extravasation when it was really just a kind of high pressure abscess going into the medullary cavity of the bone. Some other examples of pseudoflow that we're more familiar with are the swirling of kind of amniotic fluid or ascites, and then ureteral jets also register Doppler flow, even though they're not intravascular. You can also sometimes see this in large abscesses with compression of the probe. You can see that kind of swirling of infectious fluid, although sometimes that can be complicated by the external pressure that you're placing with the probe, and that can cause some Doppler movement as well. So. This was actually not the last case of pseudoflow that I saw or was fooled by. This is another case that we had. It was a patient who had been discharged from the trauma service 5 or so days before presenting and had a sternal fracture. And he came back in with a lot of anterior chest pain. And when we placed the probe on his over that area, we saw this defect in the bone that you can see pretty clearly in the left images. Again, with what looked like pulsatile flow coming through that defect. And you can really see that area of kind of extravasation of this fluid in this right-hand image here. And actually, this ended up not being blood either. This was another case of osteo. This guy had sternal osteomyelitis, and it was actually eroding through and around into around the pericardial sac. And what we were seeing here was actually the heart beating underneath that, kind of compressing that pus into this soft tissue infection above the sternal fracture. So the image here on the left is from the OR when he went for a debridement and washout. You can see that area where the sternal bone was infected and through to the pericardial sac underneath there. So when talking about the sonographic findings for osteomyelitis, some of the indirect things you may see would be kind of edema or soft tissue inflammation adjacent to bone, and specifically if you have an abscess directly adjacent to bone cortex, you should be highly suspicious for possible underlying osteo. Again, you can also see some other signs of musculoskeletal inflammation, with inflammation of the tendons, synovial capsule, or possibly even a adjacent joint effusion. Some of the findings that are more specific for osteo, unfortunately, early on in the course of the disease, about 1 to 3 days from the onset of symptoms, you may not see many changes with ultrasound, aside from some mild edema. But once you get to days 4 through 7, you usually will start to see some periosteo reactions, so thickening of that outer cortex, some sort of irregularities of the cortex, or possibly some free fluid adjacent to the bone. And then once you get farther into the disease process, days 5 to 15, that's when you'll start to see cortical erosion, subperiosteal abscesses, larger fluid collections. The clip that we're looking at here on the left is distal fingertip, and you can see this distal phalanx here. There's a large disruption in the cortical surface there with a fluid collection kind of invading down into the bone there. And so this is a person who had fingertip osteo. Some kind of takeaways from this case. So POCUS can be very useful in kind of the early evaluation of osteomyelitis, and you may encounter, once you put the probe down on some of these skin and soft tissue infections, deeper findings that may raise your concern for bony involvement and infection. And if you do happen to see pulsatile flow, in an abscess that is close to bone, it's going to be concerning for possibly communication with the medullary cavity, and should certainly raise your concern for osteomyelitis. That's all I got. That's my email if anybody has any questions or wants to get in touch with me.
Wow, thank you so much. That's a really interesting case. Again, as I mentioned before, I'd never heard of that before. So really cool catch by y'all. Any questions from the group?
I guess, hi, this Andrew Shannon here. I guess I had a question. And this is more sort of on the practical side, just because that's sort of the thing that I'm always struggling with. It really is like the consents for some of these, case studies in particular, because, with the requirement, all of the residents need the low-hanging fruit of a scholarly project. I don't care what it is, but I've got 2 months to graduate, so I better get it done. But so how do I, how do you when you're looking at you're looking ahead at the appointments, things like that, like what has been and then obviously the ultrasound, when they're interesting cases, they tend to be sick patients, and there's always an awkward time frame of trying to get consent there. I've had things where I've mailed self-addressed stamped envelope to the family, at the last known address. I've had internal medicine residents go up and track them down. Have Do you have like a process, or is it just like you've printed up a bunch of consents and stapled them all over the emergency department? And if anyone thinks they have something that might be interesting, you have them sign that as part of your, registration process. Like what have you found to be helpful in trying to get consents for these case reports?
Yes, and actually, I've tried the kind of the mailing the envelope with the consent, and trying to make it as easy as possible. And actually, for the sternal case, I tried to get that to kind of include it with this one, but ultimately, never kind of heard back from the patient, and so it's tough if if you can't catch them at an appointment. A lot of these folks, because usually, and oftentimes, I forget to get the consent, on shift as well, and so for folks that are admitted, usually we try to we'll kind of be reviewing them in ultrasound conference and say, oh, this was a great case, and yeah, we should go and get consent from them before they're out of the hospital. And so we usually try to kind of visit once their acute illness has passed, and they might be more receptive to signing consent. And so trying to catch them at the time is going to be the easiest, but often oftentimes you do forget, and then kind of following up for patients that are admitted. In Epic, there's kind of a nice kind of list of like upcoming appointments, and so sometimes I'll look at those because obviously you don't want to even if it's a nice kind of old Mima, you don't want to go to like their house or meet them kind of somewhere that's outside of the sort of the hospital system. And so usually try to find kind of upcoming appointments or follow-ups that they have for the thing that they were admitted for, and try to catch them there. And so, kind of call them beforehand, let them know that kind of remind them of who you were, and then kind of introduce the possibility of sharing their information in a case report, and then try to meet with them there. And then what we always try to do is our secretaries can scan in the consents to the patient's chart, because oftentimes it can be hard to keep track of them after the fact. And so it's a nice place to kind of store HIPAA, protected information that is easy to find and to get back to. So.
Great, thank you. We have a question in the chat that I'll read if that's okay. It says, has anyone evaluated ultrasound findings of early osteo in the absence of an abscess?
I think some of the studies that I had cited in the paper have looked at kind of general ultrasound findings and larger numbers of patients, and looking specifically for some of those kind of early findings. And oftentimes you may not see an adjacent abscess. It's going to be more sort of cortical irregularities, cortical disruption, and then when it gets more advanced, you can start to see fluid collections sort of eating away at the bone itself. But some of those early periosteal reactions can be hard to pick up, but you basically kind of want to scan, obviously starting in the normal area, and then approaching your abnormal, and kind of looking for disruptions in the cortex, and some of the start of those changes.
Yeah, that's really cool. Have you all thought about developing any kind of study regarding this? Like, also for our budding researchers on the call, any ideas for how this could be incorporated or developed into like a more um, detailed study?
I think probably the next step would be to, we do a lot of X-rays looking for osteo, and that tends to be kind of the initial sort of screening test that we're getting on a lot of patients. And I think, kind of taking a population of patients where there's a concern for osteo, and the test that they're looking for, or starting with is going to be an X-ray, and kind of comparing that to, POCUS, and seeing, if the sensitivity is higher, if we see a, kind of more early changes for patients who ultimately, are found to have, osteo on MRI.
Yeah, I think it makes sense to look into that a little bit further because, we always get X-rays obviously not great. And then the other things like MRI, whereas like
Right, usually requires
oftentimes you don't want.
admission or yeah.
Yeah, yeah. So um, POCUS would be a really cool option for people to investigate that further. So I think that's a great idea. Cool. Are you personally, or have you encouraged your residents to incorporate this into their workup and workflow for people that are worried about osteo?
Yes, certainly, it's just something they're doing kind of with one of our ultrasound faculty. But I think if we're, concerned for it, we generally, try to take a look. And,
Yeah,
and I think pretty routinely we're looking at, most skin and soft tissue infections, with POCUS and, on the off chance that, you do find something kind of surprising like we did in this case.
yeah, awesome. Cool. Well, thank you so much. Any other questions from the audience? Well, hearing none, I think we can move on to our next presenter. That's okay. Thanks again. Thanks again, Dr.
Yeah.
Shaahinfar. We really appreciate you. Great
Thank you.
paper, great case report. And also a good idea, just to build your, for those of us on the call who are looking to build our um, CV with publications and things, this is a great example of how you can get a nice publication. So, all right, next we have Dr. Zachary Binder. He's going to present his article entitled Ultrasound-Guided Nerve Block for Pediatric Femur Fractures in the Emergency Department, a Prospective Multi-Center Study. So, Dr. Binder is an associate professor of pediatrics at UMass Chan Medical School, UMass Memorial Medical Center. And a fun fact about Dr. Binder is that he can only blink with one eye, his right eye, which makes proper technique, which makes teaching proper technique for the opto exam a little bit challenging. So um, thank you so much, Dr. Binder. We really appreciate you being here and look forward to hearing about your study.
My pleasure. You guys hearing me well?
Yeah, we can hear you.
Awesome. So this
Sorry, real quick though, we can see the presenter mode. I don't know if you're able to.
Yeah.
Do you want to? I'm not sure. Yeah, that looks better. That's better.
Okay.
Perfect. Yeah, cool.
So this image is courtesy of one of my colleagues that she kind of made, and I try to use whenever possible. I just think it's a fun slide. But I'm going to be presenting the pediatric lower extremity ultrasound guided nerve block or PLEXUS study. No financial disclosures, and I'll mention this probably a couple times, but this work couldn't have been done without the help of many colleagues. The co-authors are listed here, a few of whom are on this call. I think Simone and Antonio are on this call, but took many hours of free labor to put this project together. So I'd like to thank them for that. So the premise of the study was we wanted to look at if there was a difference in pain scores at 1 hour between patients who received an ultrasound-guided nerve block for their femur fracture versus patients who did not, patients who only received systemic opioids. We had 12 sites participating in the study. The vast majority were across the United States, as you can see, and we had one Eastern Australian site. The data was collected prospectively, and this was an observational study. We included patients who were between the ages of 4 and 17 years of age, who had had a fracture within the last 24 hours and had a normal GCS. We did not exclude patients. We excluded patients with bilateral fractures, neurovascular injury, and a few other exclusion criteria that you can see there. So a quick overview for those who may be less familiar with the fascial compartment nerve block. Just a quick overview. So you'll recall that the femoral nerve innervates primarily the thigh and a bit of the inner aspect of the lower leg, as you can see here. This makes it particularly helpful for injuries such as this gash wound and classically femur fractures as seen here. We're going to access the femoral nerve within the femoral triangle, which if you'll recall from your first year of medical school, the anatomic orientation is typically nerve, artery, vein. And we rely on this relationship when performing this procedure. So again, nerve lateral to artery, artery lateral to vein. When we put the probe down on the patient's leg just inferior to the inguinal crease, this is the image that we see. So again, we're relying on that relationship whereby the nerve is going to be lateral to the artery. And you can see the structures there. The artery is the hypoechoic circle next to the more hyperechoic nerve. So the basic premise of the procedure is that you insert your needle lateral to the neurovascular bundle. You penetrate two fascial planes, the fascia lata and the fascia iliaca, and you deposit your anesthetic. And if properly placed, you should get good coverage of the femoral nerve. So this is a clip here. You can kind of see the needle underneath the fascia iliaca. We're kind of finding our spot, if you will, and starting to inject a little bit of fluid. And then as the procedure continues and you continue to inject, you get a nice pocket of anesthetic, which kind of circumvents and bathes the femoral nerve. So back to the study itself. So again, we're comparing patients who received this procedure in the emergency department to those who did not and received systemic opioids alone for their pain management. Our primary outcome was the reduction in pain intensity 1 hour post-enrollment. We had a number of secondary outcomes, including reduction in pain intensity at the 4-hour mark, morphine equivalents per hour that the patients received, any secondary adverse events, and we also looked at ED length of stay. So our two groups were pretty similar. We had a total of 114 patients, 54 in the nerve block group and 60 in the systemic opioids group. You can see the mean ages were similar, and both had a majority male patients. At the time of their enrollment, the patients in the ultrasound-guided nerve block group did have a slightly higher pain score of 6.2 compared to 5.2 in the systemic opioid group. At the 1 hour mark, you can see that the systemic opioid mean pain score had dropped to 4.4 compared to 2.0 in the fascia iliaca compartment nerve block group. So we had a reduction of 3.8 in the nerve block group compared to 0.8 in the systemic opioid group. And that difference of 3 was statistically significant. Again, at 4 hours, you see that the pain intensity had decreased from 5.2 to 3.4. And in the ultrasound-guided nerve block group, 6.2 to 2.5. So the effect or reduction in pain intensity was maintained at the 4 hour mark and had a statistically significant difference between the two groups. In terms of morphine equivalents per hour, the ultrasound-guided nerve block group required 0.3 morphine equivalents per hour compared to 1.1 in the systemic opioid group. So we had an overall reduction of 73% in the nerve block cohort. There were a few adverse events in each group. I've listed those there. None of the actual adverse events that occurred in the nerve block patients do we think was actually attributable to the nerve block itself. One of these patients had been pretty heavily narcotized before arrival. So we kind of suspected that was probably the reason for the apnea, nausea, and vomiting, and not the nerve block itself. But you can see the adverse events that were experienced in the two groups. And then kind of our controlling measure of ED length of stay, the length of stays were the same between the two cohorts, 6.1 hours in both groups. In summary, the ultrasound-guided nerve block compared to the systemic opioids alone resulted in a greater reduction in pain intensity 1 and 4 hours after enrollment, decreased opioid requirements, fewer adverse events, and an unchanged ED length of stay. In terms of next steps, Me and my colleagues have actually launched the pain block registry. So the pediatric analgesia includes nerve block registry. If you have any PEM colleagues who are potentially interested, we're always interested in collaborating, and have a particular interest in studying implementation strategies to increase ultrasound-guided nerve block use, especially in children. Again, I want to thank my colleagues who were kind of spread out both across the country and the world ultimately. Again, this was an unfunded endeavor, and took a lot of sweat equity from a lot of these folks. And I'll just end with a bit of an anecdote or story. So one patient that kind of represents my inspiration for this work, I was taking care of a 12-year-old with osteogenesis imperfecta who had had over a dozen prior fractures. He was in the emergency department, having sustained a mechanical fall, and was in quite a bit of distress, a lot of pain, a lot of anxiety. He had been kind of through this process numerous times before and was in a really kind of bad place. So we enrolled the patient, performed the procedure, and then went back to check on him a couple hours later. And hopefully this audio comes through.
I cannot feel my leg when I touch it.
So that was him, an hour after the procedure. He actually was transported to Boston Children's, where his kind of ultra specialized osteogenesis imperfecta, special orthopedic surgeon didn't require any opioids for transfer. And so that was a win, we felt. So like the prior presenter, if anyone has any questions after the fact or wants to reach out for collaboration or whatnot, always happy to chat. So that's what I got for you.
Awesome. Thank you so much. I love the story at the end and the tying it up with the clinical case. And yeah, that child's reaction is priceless. So that's awesome. Thank you for sharing.
Of course.
All right, so we can open it up to questions and start it off. I see one that was posted in the chat here, so I'll go ahead and read that. It says, just curious how you decide on dosage/volume of anesthetic used on pediatric patients. Is it weight-based, age-based? And this particular provider, it says normally seeing only adults clinically. So yeah, how do you decide on dosage volume for your pediatric patients?
Yeah, so there's well-established maximums in terms of anesthetic doses that can be used, and those are all weight-based. So depending on the anesthetic you're using, whether it's lidocaine with epi, bupivacaine, you can look it up on any number of kind of resources, and it has a weight-based maximum for you. One thing I'll mention is that in our smaller kids, that weight-based maximum may be something on the order of 8 mLs, when you convert it to a volume. And for the fascial iliaca block, you really do want, at least 15 mLs of fluid to be able to infuse, even in the smaller kids. So what we'll often do is take our kind of max dose and just combine it with saline. There's no harm in kind of diluting your anesthetic, and you get the same effect, but you do really need that volume. So if you're preparing one of these procedures and you're thinking to yourself, I'm going to need 15 cc's to have an effective block, but it's telling me my max dose is, whatever it may be, 8 or 10, you can always dilute it down. That doesn't minimize the effect.
Great, thank you. Does that max volume change based on the patient's size?
Based on their weight, yeah.
What about the volume, though? You mentioned like you dilute it with certain volume.
Yeah. Oh, I see what you're saying. I mean, generally speaking, once you have an adult-sized patient, the fascial iliaca is traditionally done with roughly 20 cc's. But even in the smallest kids, we've done these procedures in kids as young as 6, 7, 8 months. And even for those smaller kids, you do need at least 10 cc's to really open up that fascial plane. So,
Gotcha.
There's a little bit of art versus science to the total volume, but you do need a fair bit to open those planes up.
Great. Yeah. Thank you. All right, another question in the chat here says, also out of curiosity, do you happen to do anything in particular to keep the kids calm? Can imagine with a big needle coming toward them, it would be difficult to administer in some cases.
Yeah. So, I mean, I guess there's a couple ways to answer that, and that's frequently a question that we'll get. I guess one thing I'll mention off the bat is, for better or worse, a patient with a femur fracture is in a tremendous amount of pain, and ultimately is not really moving their lower body. So the thought of like the kind of hyperactive little kid who can't sit still, that's not exactly the circumstance we're kind of entering into. That being said, we do rely on kind of a lot of adjunctive techniques. I'm a strong advocate of getting LMX on the patient's leg right away. That's going to take care of kind of the initial pain of needle insertion. Most of these blocks were done at major pediatric centers where you have trained nursing and child life available, distraction techniques, incorporating the parents into kind of the procedure. But everyone always asks, like, did you have to sedate all these patients? And as you can see here, none of the nerve block patients required a proper, ketamine sedation. You can see there a few did receive Versed. In the younger kids, I'm a huge proponent of a dose of PO Versed just to take the edge off. And I found, if you combine LMX, some PO Versed, some distraction, that's usually all you need.
Yeah, I think that's a great tip. The little touch of Versed there. I like that. I had a question. I was wondering if you all had thought about or tried to do any data collection on like patient satisfaction or like family satisfaction, because it seems like, they could go one or two ways. Like parents could be like, "Oh, what are you doing with that needle?" But at the same time, obviously, it's going to be very helpful for them. So, did you all do any or attempt to do any data collection on that?
Yeah, I don't know if my colleague Simone wants to jump on. So, ultimately through this process, and I guess this is kind of a message out to those budding researchers out there. We collected like an insane amount of data, essentially. Everything from adjunctive medications to who was performing the procedure to what needle was being used. We also collected quite a bit of parent satisfaction data. So ultimately, this was kind of the first manuscript where we presented, the primary results. There was a secondary analysis that was published where we compared kind of where the needle was located at the time of injection. So comparing, more of a traditional like femoral nerve block where the needle was quite close to the nerve versus the fascia iliaca where it's not quite as close. And that was published a few months ago. And then the next thing we're hoping to have off the presses for you guys is an analysis of the parental satisfaction. It was just too much kind of data to cram into one manuscript, essentially.
Yeah, awesome. That's great to split it up a little bit. Yeah,
This
that's
can
really
serve
cool.
this can serve as Simone's little elbow in her ribs she's going to be the primary author on that paper. So
I'm on it.
mhm.
How's that process been for you, Simone?
Just trying to get through the to-do list that is academic medicine.
Yeah. Yeah, I hear you. What stage are you in right now in that process? Like, are you still getting the data into like spreadsheets and stuff,
Yeah,
or?
all the data is there. The paper, there's a draft of a draft. And so I just have to do the number crunching of the satisfaction scores between the groups.
Are you allowed to give us a little hint of what might be the result of that, or
I don't
is it
know.
a
I have to
secret?
do the number.
Okay, okay. I'm
My
super curious. I'm
takeaway
super
is that
curious.
parents were very satisfied. And so we'll see how it fleshes out.
Cool. Awesome.
I am not holding anybody in suspense. It is really, I have to be a good person and get the statistics done. I'm on it, Zach, I promise.
Anecdotally, I mean, you see the video there, so you can just picture being like that kid's parent, right? So, um, not every block do you go from, 8 out of 10 pain to 0 out of 10, but it's not infrequent. And you can imagine being the parent of a kid who has a broken leg and all of a sudden is able to kind of relax a little bit and, get their traction and sleep before going to the OR the next day.
Yeah, that's awesome. Cool. Just regarding the methods, I was really impressed with the amount of sites you all were able to use in order to get your data number. And I saw that like the expected like with your power calculation, you far exceeded that number. Um, what was that process like for you in terms of getting the group together and like you said this was not funded, so did you just have some connections and you guys just like collaborate together, or how did you all come together as a group for that?
Yeah, so that's a great question. And ultimately when people are, asking me, um, I like research, but what I actually ultimately like is kind of putting a research team together more than anything. Like that's the thing that kind of um, is my kind of motivation in this process. And so, that was kind of the fun part for me. So essentially how it all went down was this process started with just a bit of a like retrospective case series, I want to say like 5 years ago. Um, and at that time, I was only aware of like maybe 3 or 4 sites across the country that were performing these procedures. Um, so kind of got a little group together, published the case series. And then born out of that initial group was the idea that we should, do something prospective. So put kind of an initial team together, a bit of a protocol. I think the majority, if not all of us, are part of the P2 network. So that's the Pediatric Emergency Medicine POCUS network, essentially. So it's all the PEM POCUS folks, really ultimately across the world. And so once we had our protocol together, we put an ad in there, kind of listserv. Any interested sites, kind of reach out, and that's really how it kind of came together. Many of the sites that ultimately were participated, I had never met or interacted with the PI prior to kind of putting out that advertisement. So that part of it was really cool.
Yeah.
The other thing I was going to just mention, and it was a bit of a like decision that we had to make. So I kind of upfront promised folks that we would enroll for 2 years, kind of no matter what, because as you'll find, it takes sites different amounts of time to kind of get their IRB approval, their DUA in place, their, everything kind of lined up. And I didn't want people to be kind of deterred by the idea that they were going to do all this work and not be able to participate. So right off the bat, we were kind of like, our power calculation indicates that we're going to need 54 patients or whatever it was. But, if you're making kind of the earnest effort to get all your stuff together and actually join us, we're going to keep enrolling until, whatever it was, June of 2024. I can't even keep track anymore. But so there were sites that, were kind of getting onboarded as we went, and ultimately kind of had the 12 sites for the final product.
That's really cool. Thanks for sharing that. I think just it was really cool. I thought how you guys got multiple sites involved, and I think that's a good strategy to increase your sample size. So that's really cool. Cool. Great. All right. Well, any other questions from the group? All right. Great. Well, thank you again. Great study, and look forward to that patient family satisfaction paper coming out soon.